Dr. Witteles, please give us your view of the proper laboratory testing that should occur to interpret a technetium pyrophosphate scan. And then the second thing I'd like you to comment on is whether it's important to identify these unrecognized wild-type TTR cases if they're undergoing a TAVR or some other procedure.
Great, thanks. All right, on the first point on the testing for monoclonal protein, this point can't be emphasized enough. I think in 2020, at least, it is the most important point for people to understand who are doing diagnostic workups of these patients. So technetium pyrophosphate scanning is both the best and the worst thing to ever happen for TTR amyloid patients. It's the best because, or for amyloid patients, I should say. It's the best because it has allowed many, I would say most, transthyretin amyloidosis patients to get a correct diagnosis non-invasively and be able to get started on treatments that we'll, I'm sure, discuss that can make a real difference in their disease course. But it's the worst thing because it has unfortunately led to many people either getting misdiagnosed as having transthyretin diagnosis when they don't have amyloidosis at all, or really far more tragically, getting misdiagnosed as having transthyretin amyloidosis when they actually have AL amyloidosis. So it's important to emphasize, as Dr. Desai was getting at before, that positive bone scintigraphy in this country, typically technetium pyrophosphate, is not specific for only transthyretin amyloidosis. So it tends to have the most uptake with transthyretin amyloidosis, but you can absolutely get uptake with other forms, including AL. And in the landmark study that really led to its widespread use, 22% of the patients who had AL amyloidosis had positive scans. So you can absolutely have a positive scan in a patient with AL amyloidosis. And whereas it's nice and can make a significant difference for a patient with transthyretin amyloidosis to get them on treatment, it is catastrophic to miss a diagnosis of AL amyloidosis and miss the window to be able to get them started on effective light chain therapy. So with that as a preamble, nobody should get a technetium pyrophosphate scan without either concomitantly or beforehand having a monoclonal protein ruled out, and that is with 3 tests. The most important one is the serum free light chain assay, which is simply measuring the concentration of serum free kappa light chains and free lambda light chains. The ratio is typically approximately 1. If it is well off in one direction or the other, it implies there is clonal production of whichever one is off, and that person cannot have a technetium pyrophosphate test to make a diagnosis of transthyretin amyloidosis. The other tests are a serum and a urine protein electrophoresis with immunofixation. Important to note that it should always be done with immunofixation, which raises the accuracy of the test. There's no reason to do it without at this point. And what you're looking for on the serum test is mainly whole immunoglobulins, and on the urine test, you're mainly looking for light chains. Why do you need to do that in addition to the free light chain test? Well, for one, those 2 tests, if they show a monoclonal spike, those have proven clonality. Whereas with the free light chain test, you have implied clonality by the ratio being off. And if the ratio is off by 10 to 1 or 100 to 1, that's proven clonality. But if the ratio is off by 2 to 1 or 3 to 1, it's tough to say whether you have a true clonal process or not. So you really want to have all 3 tests, and only when all 3 tests are normal can you then use a technetium pyrophosphate scan to make a diagnosis of transthyretin amyloidosis. Your second question, sorry, I forgot. Your second
question was just about the significance of a finding of wild-type TTR in certain populations. Is that really important to pursue?
Right, that's an important question. To some extent, we don't know the answer to it. So we do know that treatment, certainly tafamidis, makes a significant difference in the treatment population who was studied in the phase 3 trial of tafamidis. Now, that was not in a population who was getting screening So if you start just screening everybody who is undergoing a TAVR, for example, and make some diagnosis, technically they weren't included in the ATTRACT clinical trial, the phase 3 trial of tafamidis. That being said, the results of ATTRACT were quite compelling, as I'm sure we'll get to, in terms of making a significant difference in mortality, making a significant difference in cardiovascular hospitalization, and in progression of the disease based on quality of life and 6-minute walk distance. So I think most of us, probably all of us, if we have a patient who has heart failure and who has a diagnosis of transthyretin amyloidosis, will believe that we're going to be able to make a significant difference by getting them on tafamidis. Ergo, yes, I think screening an appropriate population does make sense.